I was going to talk about the methods of meta-analyses, methods and techniques, particularly of meta-analysis, and how do we use the results from them. But I realised as I did it that I really want to talk about how would you use the results from a randomised trial to extrapolate to future patients. So the key thing when we're talking about large is the need for large-scale randomised evidence. And I want to put the methodology for meta-analyses in this context, but it's more of a footnote to this context than it is the entire subject of what I'm talking about today. So this talk is completely different from what it was yesterday. It starts off talking about really trials and how do we use them, how do we actually make sense of them. And the key thing, again and again, is the recognition that often in trials you're looking for moderate differences in outcome, relative risk, let's say, of 0.8, 0.9 even, not for 90% reductions, not for even 50% reductions in serious outcomes. When you've got huge effects like that, actually you could recognise them without randomisation, although randomisation can certainly help because it avoids various sorts of biases. But for example, when we got the early results from the COVID vaccines, there was about a 20-fold relative risk. Well, that would have been recognised sooner or later, but it was recognised sooner and without any dispute because these trials were randomised, those trials were randomised. And the same, well, with the recovery trial, I think, and with treatments of COVID, again, we're in the realm of moderate differences, not 20-fold differences. And without the randomisation in the recovery trial, there would have been all kinds of nonsense believed about what works and what doesn't work in the treatment of COVID. It's bad enough with serious evidence. Without serious evidence, but it would have been in a disastrous situation. But if you're trying to pick up moderate effects, then trials have got to be an order of magnitude larger than they traditionally have been. And they're already hideously expensive. But the key thing is this need for reliable assessment of moderate effects. I mean, there's Richard Peto over there. He sorted out that smoking caused lung cancer, was a cause of lung cancer. Sorry, he's very particular about that. Without randomising, because the effect is so big. You know, maybe non-smokers are a bit different from other people in other ways that matter, but the effect of smoking was so extreme, there was no possibility of the results being wrong. It had to be a cause of most cases of lung cancer in Britain in the middle of the last century. So, but when we're talking about treatments, that is in general not the case. And this is the thing that has the key implications for clinical trial methodology, the interpretation of clinical trials, and then in turn meta-analyses. So it's this need for the assessment of moderate effects on serious endpoints. I've said on mortality, but of course there are other serious endpoints that you could have. Now, before I even go into that, what use are trial results? I mean, the patients in a randomised trial are not a random sample of anything. And apart from anything else, all patients in clinical trials are in the past, and all patients you want to treat are in the future. And patients in the past differ systematically from those in the future. And they'll differ in other ways too. You know, if you're doing a chemotherapy trial, you're not really going to try some new chemotherapy out on patients who've got all sorts of other medical problems. The patients who get into the trials will be generally healthier, I would think, but it could go the other way. They could be less healthy. But they're really very different from the patients not in trials in ways that you can characterise, like you can describe ages and so on, and also in ways that you can't. And so the question is, how should statistically reliable trial results influence doctors and individual patients? Suppose we've got a trial that's really given a very definite answer, or a meta-analysis to that method, but I want to pass over the complications of meta-analysis, but just think, how should an individual trial result affect doctors, how they advise patients, what decisions the doctors take, and individual patients? How much, should a patient be influenced by trial results? So how can we extrapolate trial results, which are all in the past, they're all in highly selected patients selected in ways we don't know, to many very different types of current and future individual patients. Each patient's got lots of things that are special about them. And you can't find, even if you knew all the characteristics of patients in the trials, you wouldn't be able to find a group of patients, a sufficiently large number of randomized patients who are similar to the one you're trying to look at now, to talk any sense. So you couldn't get an informative group that's the same as the patient you're looking at. So you've got, so do trials tell us anything? Yes, but it's how should we use the results to help decisions on the treatment of individual patients? And I'm going to use an example from 35 years ago or so, which is the ISIS-2 trial of aspirin. This is very familiar here. It must have been lectured on about 30 times in this lecture theatre and in lecture theatres all over the world. But it is a beautiful result, and I want to say, what would we say about this result if there wasn't any other randomised evidence on aspirin or other antiplatelet drugs? Aspirin was tested because it stops the platelets in your blood collaborating in the formation of thrombus. Okay, so when you form thrombus, it's the combination of proteins and platelets sticking together, and red cells as well, sticking together and make it a big structure, and the platelets don't collaborate in that process if you've just taken half an aspirin. Half an aspirin is enough to keep the platelets inactive for the next 24 hours or more. So we did a trial of half an aspirin a day versus dummy pills in 17,000 patients. Actually, Rory Collins did it, but certainly I was involved in it. Very much enjoyed analysing these data, working with Sarah Parish on the analyses. But here, suppose that's the only result there is. Now here we are in 2022. Now, the patients now are different. The prognosis of patients in heart disease is much better than it was 30 or 40 years ago. Other treatments are given. In those days, some patients got blood clot dissolving treatment, some didn't, but nobody was getting a sort of mechanical removal of the thrombus that's blocking their coronary artery. But actually, that's very common now. Lots of the patients nowadays wouldn't have clot-busting drugs at all, but they'd have the thrombus just taken out, the thrombus that's causing a heart attack taken out. This is different, and we've got all sorts of other different drugs that we're giving to patients, and overall, the mortality is much lower than it was. So is this old result still informative? Yes, if you actually use trial results in the right way. You can take the relative risk in this. I mean, the absolute difference, as you can see, well, 11.8% dead versus 9.4% dead, difference of about 2.5%, an absolute gain of about 2.5%, based on 1,000 deaths versus 800 deaths, so 5 standard errors. And in fact, further evidence that it also reduced the likelihood that you have another heart attack while you're in hospital, and reduced the likelihood that you have an occlusive stroke while you're in hospital. So all kinds of reinforcing errors. This is a definite result. But what does it mean for patients coming into hospital today with a heart attack? Well, the overall risks are much lower, so probably the overall benefit is much lower. But nevertheless, the relative risk could carry over. The gain here may have been 2.5%. The gain in typical patients nowadays might be 1%. I don't know. But it's going to be in the same direction. That's the assumption. It's the same direction and of comparable magnitude. Even the relative risk may not be identical now. Why should it be? And also, yes, male and female. Why should the relative risk in male and female be identical? Well, they don't have to be identical, but they should be much the same. Males and females got platelets for much the same reason. So, it would be very odd if it was supposed to work in males and not in females, or vice versa. And the distribution of ages in this modern patients nowadays is much older than in the ISIS trial. I mean, there would have been very few over age 80, and yet lots of heart attack patients now are over 80. COVID has shown us that what happens in older patients may be very different. So we can extrapolate the relative risk semi-quantitatively from the ISIS-2 trial to the present. And I mean, there is actually some other evidence around. I mean, the Chinese collaborators just did a beautiful trial about 10 years ago, 10, 15 years ago. Chen Jianming was the PI of it here, looking at single antiplatelet therapy with aspirin alone versus double antiplatelet therapy with aspirin plus something else, another antiplatelet agent, and showed that the double treatment was a bit better than the single treatment. So we do have other evidence, but what if we didn't? Well, still, I would say that result should guide current and future practice. It should be a guide to what to do in the 2020s and 2030s, unless there's some very specific, strong reason that it's not appropriate. So how do we actually use that result going forwards? And the same is true of meta-analyses. Generally, we want to use semi-quantitative extrapolation of the relative risks, not the absolute risks. from many different and ill-characterized types of trial patients. And, there weren't any Chinese patients, or at least there weren't any Chinese centers in the ISIS-2 trial, but nevertheless, aspirin, when the results came out, started to be used all over China. Jolly good. It's the right thing I'd want it too if I were a Chinese patient. And there weren't any African centers in the study, well, at least not in sub-Saharan Africa. And so on. So the patients in there are different, and yet the results apply to patients in different populations, completely different populations, half a century later, because the results are so definite. So we've got semi-quantitative extrapolation of the relative risks from many different types of patients. And it's not that the relative risks in every type of patient must be identical. There's no reason why they should be. They probably aren't if we can measure them precisely enough. So the assumption isn't that all the patients in the trial are similar. In fact, the main reason why you do randomization isn't because all the patients are similar, it's because patients are so different. And it's only by randomization you could at least ensure that there's no systematic differences between your treatment group and your control group. And if you do big numbers as well, if you get large-scale randomized evidence, then there aren't going to be very big random errors either. So it all comes down to the need to assess moderate effects reliably. And the requirements for this, again, these have been listed before, but I'm going over them because they do carry implications for meta-analyses. If we're trying to assess moderate effects reliably, we want to say, does something have a moderate effect, or does it have no material effect? Then you really need negligible biases. And the only way you can get that is by randomization. You can't get it by selecting your patients and trying to get patients that are identical who you'll treat to some other patients you won't treat. You'll get systematic biases if you do that. And even if you happen to get the right answer, you won't know you have, nor will anybody else. And you also have to have, because you're going for moderate differences, small random errors. So you need negligible biases and small random errors. How are we going to guarantee the avoidance of moderate biases? You can't have moderate biases if you're trying to assess the moderate treatment effect. You can't have moderate biases. Well, proper randomization. And randomization is, the reason for it is to make the doctor and patient who are deciding whether to go into the trial, that there's going to be no systematic difference between those allocated active treatment, those allocated control treatment, or if it's comparing two active treatments, there's allocated treatment 1, there's allocated treatment 2. It's to ensure ignorance. It's to ensure blindness of who's going to get what treatment. And if you don't do that, then you do finish up with moderate biases. I mean, COVID's shown that very clearly again and again. So non-randomized methods may suffer moderate biases. You can't stand moderate biases if you're trying to assess or refute moderate treatment effects. And again, analysis by allocated treatment is ought to be available in your report. This is now routinely made available, but actually it used not to be. People used to exclude the patients who didn't get treatment exactly as the protocol stated. They call them per protocol analyses. And in general, it's just junk. They're just useless. The analysis ought to be by allocated treatment. So you randomly allocate those where both treatment options are reasonable, and then try and make sure that they do actually stick to what's allocated. But whether they do or not, you don't exclude those who don't stick to the allocated treatment. This stuff's all classic standard stuff. It's been in textbooks for decades. The chief emphasis should be on the overall results, because you can, if you just take a trial result and you subdivide it in dozens of different ways, which is done in virtually every Lancet trial report, in virtually every New England Journal trial report. All trial reports do this. They've got a table giving the results in this, that, and the other subgroup. And it's just crazy. I mean, most trials aren't big enough for the overall results to be informative, let alone the results in particular subgroups to be informative, and let alone, nonsense on top of nonsense to really tell whether one subgroup is seriously different from another. And even if they seem to be different, and even if it seems to have zero effect in some subgroup, probably the best guide as to what treatment does, unless there's some good reason for expecting zero effect in that subgroup, is the average of the unduly promising subgroup results with the unduly unpromising subgroup results, some sort of average. And again, this is to say that we go for the overall results isn't to say that the relative risk is identical in all subgroups. That's not the claim. The claim is it should be semi-quantitatively similar, same sort of general direction. And then finally, you want to do a systematic meta-analysis of all the relevant randomized trials with no unduly data-dependent emphasis on particular studies. We don't want to say, look, I like this trial because it shows that this treatment doesn't work, or I like this trial because it shows the treatment does work. You know, if you emphasize the trials with striking results, then they'll be atypical. They could well be atypical. You need to get all the randomized trials together, or virtually all of them together, on the same piece of paper, and then make a sort of, we used to call it an overview rather than meta-analysis, but it doesn't matter what word you use. But you want them all in front of you when you're trying to judge whether the treatment works. Remember, you're trying to make a semi-quantitative judgment as to whether it works. So you need the meta-analysis in order to avoid biases. You get moderate biases if you get undue selection on particular trials. And finally, to get small random errors, you've just got to have large numbers. To be really large, trials should be streamlined. They should be as simple as is legally allowable, and the laws ought to be changed to make things more streamlined. There are some little details that I'll just put in. I think that the use of minimization in randomization is a good idea because it ensures that there isn't too much imbalance. You can use a technique called minimization to make sure the randomization doesn't stray too far from similarity in any particular subgroup, as long as you don't minimize on center. You mustn't minimize on center because then the doctors at that center can make a guess that the next patient is going to be the opposite of what the previous one was. But if you minimize on everything else, then you'll have good balance with respect to age, sex, this and the other thing, you know, severity of disease. So if you can get some crude measures like that, you can actually do a little bit better than pure randomization. And it means that the stratified analysis of a trial that does correct for any chance imbalances is almost identical to the analysis of the trial that doesn't correct for any chance imbalances. I mean, it's difficult to know what to do in a trial when, for example, the recovery trial with dexamethasone, by chance, the patients who got given dexamethasone were about a year or two older than those who didn't. Could such a thing arise just by chance? Yes, it did. It was proper randomization. And in fact, dexamethasone is better than the crude analysis would suggest, quite appreciably better. You know, a couple of years older with COVID, there's a big difference in prognosis. And the appropriate analysis there is the analysis which does allow for that chance imbalance in age. Just as, you know, if you were, you know, just doing a coin toss on every patient who came in, you'd choose to, you know, if you got 40 patients allocated one treatment and 60 allocated the other, you know, with your coin tossing just by chance. And then you analyze treatment versus control, 40 treated versus 60 control. Okay, it's random, but you'd probably take number of deaths divided by denominator, you know, number of deaths in the treatment group divided by 40 versus number of deaths in the treatment group divided by 60. And that's really all that's being done when you do analyses that are stratified for, that are adjusted for any chance imbalances. So use minimization so you don't get much in the way of chance imbalances. And I think the stratified analyses or the adjusted analyses are actually preferable. But what you mustn't do is do anything that allows the doctors to have foreknowledge of what the next patient's going to be. And then finally, for small random errors, again, you need a systematic meta-analysis that yields the largest possible total numbers. Okay, summary. You need all the main trial results to avoid undue emphasis, and we've got to avoid unduly data-dependent emphasis on particular subgroups or particular trials. Well, I'll briefly mention the joke subgroup thing. Back in the ISIS-2 trial, we sent it to the Lancet, and the Lancet said, oh, great, you know, we'll publish this, but you've got to do subgroup analyses and tell us who benefits. And we've been saying for years, you know, these were in principle wrong. And so he said, no, it's a matter of moral principle. You know, we can't do that, you know, it's bad science. And so, well, the referees say that that's what's needed. They want to know which patients benefit. And if you don't tell us that, we're not going to publish it. And we said, no, it's a matter of moral principle. So, okay, we're not publishing. And so, obviously, we said, yes, we do it. And but we got our sort of revenge in. And we actually got a pretty good subgroup analysis because we also took the local newspaper and got, you know, Capricorn, Gemini, what your astrological birth sign is, and classified the patients in 12 groups. And of course, if you get a really strong positive result like that, you know, 5 standard errors on mortality, even with, you know, if you divide that into 12 subgroups, you're bound to be able to find some subgroups where the true effect is twice as big as it ought to be, where the apparent effect is twice as big as it ought to be, and other subgroups where it's 0. And of course, we found that we could just pick out, yes, Libra or Gemini. And we picked them out as showing no effect of aspirin. In fact, Capricorn, aspirin halved your risk of death. the Lancet said, well, all right, you've got the subgroup, so that's acceptable. You have to delete Astrology, that's not serious. And we said, no, that is the only subgroup analysis there that is scientifically serious. It's all the rest that are not serious. And so it went in, and that's the first subgroup analysis in figure 5. It's great. I like that. They really thought we were taking the piss, but we weren't. We were very, very serious. Subgroup analyses kill people. So you take something that works. Oh, here we are. Here's the Astrology. Libra, Gemini, birth signs. Now, okay, on to meta-analyses. I'll do them. And first, a treatment that was proposed quite strongly in the 1970s and then 1980s was giving an infusion of magnesium to people who are having a heart attack. There are various things that magnesium does to nerve cells and muscle cells and so on. And, you know, in experimental animals, it ought to have been protective, and it's cheap and safe and so on. And so various studies were done of magnesium, small trials, which indicated a fantastic result, you know, something like halving risk of death. And, you know, people were wildly enthusiastic. Other people thought this had to be rubbish. And we eventually managed to get the ISIS trial group to randomise magnesium versus no magnesium. I'd actually managed to randomise 58,000 patients, magnesium versus no magnesium. And because the small trials in aggregate, so here are the top 9 small trials at the top that we knew of when doing the magnesium starting the ISIS trial. There were the 9 small trials with 42 versus 86 deaths in them. Well, that's fairly good. I mean, why is that? I don't know why it is, but it did seem too good to be true. And although in general Bayesian analyses are nonsense, there is a rule that says if it looks too good to be true, then it probably is too good to be true. And that was the case here. You know, just in retrospect, for some reason, this just isn't a true result. Then there was the Leicester trial, Leicester Magnesium, I can't remember what it stood for, trial, which looked promising. Well, at least that was a serious trial, the second line down. So the top line, the 9 small trials, 42 out of 754 versus 86 out of 740 deaths reported in all the small trials we could find. Then the Leicester study, Limit 2, which was 90 versus 118, not statistically significant on its own, but nevertheless promising. So we thought, well, maybe, you know, that's the sort of result that was seen in ISIS 2. Is what with aspirin, it's getting into the reasonable range. It could be, there is something as good as that. But then the big blob down the bottom, the big square, is ISIS 4, 58,000 randomised, 29,000 versus 29,000, and absolutely no difference. In fact, it went non-significantly the other way around. And so if you add up everything together, you've got 2348 versus 2307 deaths. If you took, by then you've got data on 60,000 patients. And people were absolutely furious with Rory for being the principal investigator of this trial. There's still some websites around, pro-magnesium websites around in places, claiming that he's caused vast numbers of deaths by his deliberate obfuscation of magnesium evidence. And the various American groups were so certain that, you know, we'd done something wrong. Maybe we'd mixed up the drugs. Maybe we just, I mean, this couldn't be true. They were quite aggressive in attacking the trial, and they eventually set up their own trial. And they wanted all details of what we'd done, so Rory gave them all the details. And they set up their own trial, and eventually, after a few years after the ISIS work came out, absolutely dead negative, and they were just really very nice and, you know, apologised very, very nicely. And so here's the final totality of the evidence. So the top trials are the few we knew about. And then there were some more small trials that we didn't know about when we were starting to do the thing, but they also looked amazingly good. So if you take all the small trials together, well, it's microprint, but the slides are available for people afterwards. Take all the small trials together, excluding Limit 2, then you've got, let's see, what do we have on the screen there? Yeah. Then you've got 90 versus 118. So 90 versus 118 deaths in the small trials. So that's that's right, I'm reading the results for Leicester. The small trials were looking ridiculously promising. And we've got people, you know, experts on meta-analyses who've got what's called a random effects method to meta-analysis, which gives much more weight to small trials than big trials. I mean, in fact, I think that's the wrong way around to do it. I mean, patients in big trials probably a better source of unbiased information. But anyway, when trials are very different in size, then the random effects meta-analyses can give much more weight to the patients, the events in small trials and the events in big trials. And so somebody worked out that if you were doing a random effect meta-analysis, then no matter what was found in the ISIS-4 trial, a random effects meta-analysis is going to say that there is a highly 0.01 significant result in favour of magnesium, no matter what is found in the ISIS-4 trial. Any method that, so he was attacking, he was trying to nobble our data monitoring committee, talking to Paul Meyer, who was the statistician on the data monitoring committee, and saying that Paul was collaborating in an experiment that was as unethical as the Tuskegee syphilis study. I mean, somehow unethics always goes either back to Mengele or Tuskegee. But because no matter what our trial results, there would still be a highly significant meta-analysis in favour of magnesium. And this is just ridiculous. I mean, it's just that the method was ridiculous, of just giving far greater weight to the small trials than to a trial which is about 30 times their size. So then we got the big black box at the bottom is the ISIS-4 results, and then underneath it is the US one on 6,000 patients called MAGIC. It's magnesium something or other, magnesium in cardiology, I think. So it's and which got 475 versus 472 deaths, and at that point people stopped saying that we'd done something wrong and said, yes, this is an interesting example where the small trials really gave the wrong answer. But it's still relevant, not for the magnesium thing, but for the random effects model, because random effects models are still very widely used, and where trial sizes are very different, they can give much greater weight to the events in the smaller trials, which I think is actually the wrong way round. These are probably less reliable, certainly they were here. Whether that was chance or very systematic biases, I don't know, probably a bit of both. Okay, so that's an example of a meta-analysis where the meta-analysis that was not of adequate size and which didn't actually provide large-scale randomized evidence. So a meta-analysis isn't going to get the right answer if, when you put everything together, there isn't enough randomized evidence in the world to answer your question. And for most questions that get addressed by meta-analyses, that is the case. Most trials fail to answer the question they address, and most meta-analyses fail to answer the question that they address reliably. So it's not just, you don't just have to have randomization, you don't just have to have meta-analysis, you've got to have big numbers. It's got to be large-scale randomized evidence analysed without bias. And the reason, because we're interested in moderate differences, if magnesium had worked, it could easily be given to 10 million people a year, save 100,000 deaths a year, and it's worth doing. Cheap, doesn't cost anything. So here's another one where the meta-analysis of small trials was actually strongly confirmed by the big trial. So one-shot clotbuster, when somebody's got a heart attack, it may be because they've got a clot blocking an artery. You can put in a clotbuster drug, just one treatment, just give it, infuse it, or you can actually inject some in there, and it'll just dissolve the clot. And it's like Drano, when you've got a blocked drain, suddenly there's a sort of puff of smoke and the water gurgles away. And so you can give these drugs. Now, they're obviously dangerous because maybe your brain is being held together by a blood clot, in which case you'll dissolve that too, and you're going to cause a hemorrhagic stroke, which can be catastrophic. So they were known to be dangerous, but were they any good? Are clotbuster drugs any good? And actually, there'd been about 25 trials of them. The first trial was published in 1959, and by the late 1970s, there was a European collaborative trial, Clockbusters, which came out with actually quite a promising result, accompanied by an editorial in the journal saying that, that Clockbusters were dangerous and ineffective, and in my judgment, these should not be used. But if you put all the evidence together, it looks better than the magnesium evidence, but looked pretty good. And so we used that to plan a large trial of Clockbusters, and the results are beautiful. I mean, they were as good as Aspirin. And the Clockbusters by then were out, some of them were out of patent. And that's really nice. And there you are, there's the meta-analysis of all the trials. These slides are online, and you can see the detail when they're online, even though you can't see it on the screen now. So there's the meta-analysis of the small trials, total about 5,000 patients. And then the big trials came along on a total of about 60,000 patients, 55,000 patients, 60,000 in total. And then when you put together the data from all the trials, small or large, then we actually got, yes, Clockbusters do work, but they work in a rather interesting way, in that the sooner you give them, the better they're going to work. Now, people were claiming that Clockbusters could work only if they were given in the sort of first hour or two after the heart attack, because in experimental animals, if you tie off the coronary artery, the stuff downstream dies within about 2-3 hours. Anyway, so, we got told it was unethical to do test Clockbusters after the first 3 hours because they couldn't work and they could cause strokes. But here you've got the, I just named it. There's no pointer on this, but you can see that along the bottom it's hours from symptom onset, and each one of these points is a meta-analysis of all the Clockbuster trials among people who were such and such a number of hours from symptom onset. And the sooner you get them in, the better. But even 6 to 12 hours, you've got an absolute benefit of about 2%, 20 per thousand. And some people don't get into hospital in the first few hours after a heart attack. And to get it in within the first hour, you'd have to have a heart attack in hospital, which does happen, but not very commonly. Most heart attacks are out in the community. So the meta-analysis, so the big trials really gave a very nice answer, saying, yes, there are differences between different subgroups. And if you leave it long enough, then you get to the point where basically the heart muscle is either reperfused already or dead, and you don't get any benefit. But there was a very definite dependence on time since infarct. So again, the meta-analysis is more informative. If you want subgroup analyses, you're really going to need big numbers, and for that, meta-analysis can become useful. I'll go through a few more and then try and get on to some of the details. Vitamin A supplementation and child mortality. There were a lot of small trials that said that you could prevent about a quarter of all child deaths in poor countries just by giving vitamin A drops every 6 months. So a much bigger trial, a trial much bigger than all the rest put together, was done, called the Devto trial. I don't remember what Devto stands for. Deworming and enhanced vitamin A, that's right. Which randomised 1 million kids, a cluster randomised 1 million kids. And the results of the Devto trial were much less promising. The 8 small trials gave a relative risk of 0.77, suggesting a 23% reduction in child mortality. And the Devto trial gave a relative risk of 0.96 with narrow confidence intervals because it was bigger than everything else put together. And if you look at the square, the big black square at the bottom is Devto, and the white square above left of it is all the other 8 trials. These are not compatible with each other. There's a 0.001 difference here. These are heterogeneous. Every reason for that heterogeneity has been investigated. The compliance in Devto was good. The effect of the vitamin A on preventing vitamin A eye disease was real. It was done biochemically. You could choose random samples of the kids that were supposed to be treated, and they got the vitamin A in their blood. Yes, they've been treated. When it was, as a machine, it worked. Counting the child deaths wasn't difficult, and yet the results really are discrepant. And I think that just a weighted average of those 2 results is perhaps the best estimate of what the truth is. And that's what the diamond at the bottom gives. It gives a weighted average. So the old trials were too good to be true. Devto was misleadingly unpromising. And the best estimate is 0.89. Now, the vitamin A question got incredibly polarized. And the pro-vitamin A people just thought that it was unethical to do Devto. And there are lots and lots of kids just were not getting vitamin A. I mean, it wasn't actually happening. So, and we thought if it does really work, then we'd like to get evidence of it so that it does happen. But you've got very, very polarised debates as between people who are absolutely certain vitamin A is the bee's knees, and other people are certain it's really bad and does nothing at all. And so there was really quite virulent arguments about this, and mostly kids were not getting vitamin A. So and both sides are agreed that the Devto trial is completely useless. So we seem to that this meta-analysis is wrong. I think the meta-analysis is right. It's the best estimate, but the vitamin A enthusiasts still never cite Devto and never cite the meta-analysis, and the people who are against vitamin A cite only Devto and don't cite the other trials. It's just anyway, private satisfaction of believing that we're right. So the mortality reduction is still highly significant, but it's only about half as big as it was thought to be. Okay, breast cancer briefly, and then COVID, but then some more principles. breast cancer death before age 70, the risk has gone down by half since 1990. So in the US, UK, the risk has gone down by half, and that's because treatment is better. And the improvements in treatment, there hasn't been any big breakthrough like aspirin and clockbuster treatment. It's been one small boring gain after another, but finally we've actually halved breast cancer mortality in middle age, by getting the treatment better, getting the details right. And this has come, but actually the trials weren't big enough to get right answers. The separate trials of chemotherapy, of radiotherapy, of endocrine therapy, they weren't big enough to get the right answers. And it was only when all the trials of the world collaborated that they could actually get clean answers, just saying, do these treatments do anything to 10-year survival? And the answer is yes. But, and then you get enough moderate gains and you finish up with a big gain, halving national mortality rates. So what happened was that we got a thing called the Early Breast Cancer Trials Collaborative Group, which is still running here from this building. Early breast cancer is cancer that's detected only in the breast or local lymph nodes. So it's detected only locally. So you can do surgery to get off what you can see in the breast. You can do surgery to the armpits, and you can give radiotherapy, if you like, to the breast and to the armpits. To sort of, but these treatments don't deal with anything that's already spread to the rest of the body. So after removal of detected disease, micro-metastatic disease may remain elsewhere that eventually turns really nasty and kills you. Actually, most breast cancer deaths are due to micro-metastatic disease that wasn't visible when the woman was first treated. So, to assess any moderate survival differences, all the world's trials shared their data every 5 years, starting in 1985 and still continuing. And I'll just show a few quick results. So, moderate survival gains from radiotherapy, especially after breast-conserving surgery. If you just take out a bit of the breast and leave the rest of it, then cancer can come back in the conserved breast. And people said, well, that wouldn't matter too much, because if it does come back in the conserved breast, you can always take that off as well. So, you could avoid mastectomy in most women. But so it wasn't agreed as to whether radiotherapy would save lives after breast-conserving surgery. Endocrine therapy, breast cancers are often being driven by the female hormone estrogen, and if the breast is driven, I don't have breasts because I don't have female estrogen in my blood, but if you get breasts because you've been stimulated by estrogen, and if one of the cells turns into the seed of a growing cancer, in general, it's still dependent on continued stimulation from the body's estrogen, so cut that, and you can actually shrink and maybe do something to survival with the cancer. And then chemotherapy. So poison. So here's the trials of radiotherapy with 10,000 randomized. Yes, there was the expected big effect on recurrence, but most of that was recurrence in the conserved breast. So you're preventing recurrence in the conserved breast. But are you affecting breast cancer mortality? Yes. If you look out, but you don't see anything in the first 5 years. The deaths in the first 5 years are from cancer that's already spread, and radiotherapy can't catch the cancer that's already spread. So there must be some cancer that's still left around in the breast and the armpits, and sterilization of that prevented it developing into fatal incurable cancer. It's a small effect. It turns up in the second 5 years, not the first 5 years after the radiotherapy. But it's real. It's real, and we know it's real because we've had 10,000 randomized, and the trials all got put in all the trials together, and then they all collaborated. And then, what about tamoxifen? Tamoxifen blocks the estrogen receptors in your breast. Give tamoxifen every day for 5 years. Well, it's got side effects, but will it actually affect mortality? And there on the left, you can see what it did to breast cancer recurrence. It greatly reduced it, and this reduced not only local recurrence, but also distant recurrence, and also had a very nice effect on breast cancer mortality. But the tamoxifen was given for only 5 years. If you look at the right-hand graph there, it's interesting. When you look at the first 5 years, you don't see the main effect of tamoxifen. Out at 10 years, it looks better, and out at 20 years, it looks better still. But really, the main effect is after the first 5 years, so it's after the time when you're giving your 5 years of tamoxifen. There's this carryover effect. It's rather beautiful. And so it's really, and this came when all the trials were put together. So this is tamoxifen. I'll show you, I should be more precise. This is tamoxifen in women who've got estrogen responsive breast cancer, but you can tell whether it is or not on the first biopsy, and most breast cancers are. So endocrine treatments, 5 years of tamoxifen versus nothing, relative is 2/3, prevent about 1/3 of the breast cancer deaths. And then there's an even better way of stopping the estrogen escaping and getting to driving the breast cancer cells, and that's called an aromatase inhibitor, AI. AI versus nothing gives you a relative risk of about 0.6, and then 5 years of an AI versus 5 years of tamoxifen, well, the AI does better than tamoxifen in a directly randomized comparison as well, so definitely aromatase inhibitors are better than tamoxifen. Now, they were tested, aromatase inhibitors were tested only in postmenopausal women because the aromatase, the postmenopausal women use an enzyme called aromatase to make their estrogen. Premenopausal women don't, they make it in their ovaries, and aromatase inhibitors aren't going to stop that. So these trials that are up on the screen here, these were in postmenopausal women, and yesterday, 3rd of February, 2022, the meta-analysis, the EBC-TCG meta-analysis of aromatase inhibitors in premenopausal women whose ovaries were also being turned off. So double endocrine treatment, turn the ovaries off and give an aromatase inhibitor. And the aromatase inhibitor is better than tamoxifen in those women. And this was disputed. And actually, if you look at the Lancet Oncology paper on that, one very nice feature of the way is that because they only had about 4,000 women, and so although they've got definitely AIs are better than tamoxifen, they get silly subgroup effects where they're not, where they don't seem to be. And they've put the premenopausal and the postmenopausal together and show that really you don't see those silly subgroup effects in the postmenopausal. And for the premenopausal, you'd be better looking at the overall evidence. So it's quite nice. I mean, that's the update to this that really came out yesterday from EBC-TCG in this building. And lastly, chemotherapy. This is crude chemo, but there was a certainty, people were very certain that chemo wasn't going to work in hormone-sensitive cancers. And it's just not true, but it's still very strongly believed. But when you do the meta-analyses, actually the effects of chemotherapy seem to be very similar in ER-negative and in ER-positive cancers. And then there were claims that you'd get effects only in women who are under the age of 50. Well, that turned out not to be true either. So when you start subdividing, this is not trials now, these black squares. The top one is ER-negative, ER-positive, which you just saw, those top two black squares. And then you can subdivide by things like age and various things, which was said to determine who's going to benefit from chemo. You see the relative risks seem to be very similar in all these different subgroups. So, and then you can do, for chemotherapy, you can do older chemo versus no chemo, giving you a relative risk of about 0.79. Then you do stronger chemo versus older chemo, giving you a relative risk of 0.85. That suggests that strong chemo versus nothing would give you a relative risk of about 2/3. And just the record, there are the EBC-TCG collaborators. Okay, now I'm going to just go through some statistical details on meta-analyses. And this is slide 30 out of 40. And I apologise for the lateness. It's now 2 o'clock, so people should feel free to leave if they want to. There's no discourtesy in doing so. But I'm going to run on through what was going to be the tail end of this talk, because this is the one where I deal with the methodology and with what is going on with random effects models, finishing up with pointing out just the disastrous effect they would have had in COVID had they been adopted. Okay, so just the statistical detail. How do we do meta-analyses? Well, a very good way is just to calculate observed minus expected within each trial. So suppose that I've got 40 deaths in the treatment group, 60 deaths in the control group, total 100 deaths, and the treatment and control group are the same size. Now, if the treatment and control are the same size and we've got 100 deaths in the two groups together, then if treatment didn't work, you'd expect about 50 of those 100 deaths to be in the treated group, but actually you observed 40. So you've got 40 observed versus 50 expected. An observed minus expected of minus 10. You've got fewer deaths observed than expected. Conversely, you're going to have a difference of plus 10 in the controls. But so if the difference is 20, 60 deaths versus 40, then the observed minus expected is going to be minus 10. So it's about half in an evenly randomized trial. Anyway, so this is just standard observed minus expected. You can do it for 2x2 tables, classifying just treatment allocation versus dead or alive, or you can do it by log rank methods, which basically again gives an observed minus expected. But the key point is that you can also calculate, if you've got a 2 by 2 table, you can calculate the variance of observed minus expected. And this was sorted out about 100 years ago. And so if you've got 3 trials, trial 1, trial 2, trial 3, and so we got O1 minus E1 in trial 1, that's observed minus expected, with variance V1, and the same in trial 2, trial 3, then we just add them up. If each of those observed minus expected differs only randomly from 0, then the grand total should differ only randomly from 0. And because these trials are independent, the variances of independent things precisely add. And so the total of the variances would just be V1 plus V2 plus V3. And so we can say, does this grand total differ systematically from 0? Well, okay, with 3 trials, maybe you don't need to do any form machinery to try and make sense of them. But when you've got 33 trials or something, then it's helpful. And so it turns out that this is extraordinarily optimal. This method is extraordinarily optimal. Now I'm going to show one complicated statistical slide only, which is the next one. So if the next slide looks a bit baffling, then don't worry. Just trust me, adding up observed minus expected and adding up the variances is extraordinarily efficient as a way of detecting whether anything is going on. It makes the most efficient use of data. And the variance is, in a sense, the amount of information that each trial provides. Now that's odd, but now you normally think of the bigger the variance, the less you know. But actually, in this case, the bigger the variance of observed minus expected, the more you know. So, for example, if you just had, one death, which could either be treatment or control, then the expected is a half. Observed minus expected is either 0 or minus a half or plus a half. And the variance of observed minus expected is a quarter. But if instead of having just 1 death, if we'd had 400 deaths, then the variance of observed minus expected would be 100. And obviously, where a trial we've only got 1 death is only about 1/400th as informative as a trial where you've got 400 deaths. And that's because so the variance of observed minus expected is going to be small, and its variance is going to be small. So the variance of observed minus expected is actually a measure of how much information you've got. Big variance of observed minus expected means you've got lots of information. A trial with 1 death has a variance of observed minus expected of a quarter. A trial with 400 deaths has a variance of observed minus expected of 100. So 400 times more informative. And so you can think of the variance as being how much information content there is. And in fact, when you see all those pictures drawn with black squares, the bigger the black square, the area of the black square is conventionally proportional to the variance of observed minus expected. In other words, it's proportional to the information content, or if you like, it's roughly proportional to the number of deaths in that trial. So that's the information content. Now, why is just crude addition the best way to go? So there's a technical answer to this. I'm showing you the technical answer. If it looks too complicated, then forget it. So the rest of it's going to be more back to basics. So here's the same trial 1, trial 2, trial 3, basic statistics, observed minus expected, its variance. Now, we can do a calculation from the basics, and it turns out that the ratio of observed minus expected to its variance, extraordinarily, and for reasons I'm not going into here, is a very good estimate of the logarithm of the odds ratio. Or if we're talking about death rates, we're doing a Cox analysis and so on, then the logarithm of the hazard ratio, the logarithm of the death rate ratio. So and if you're doing logistic stuff, then you work with log odds ratios. And it turns out that O minus E over V is, for the sorts of relative risks you're going to get in trials, a very good estimate of the log odds ratio. It has the advantage as well that it could be done on the back of an envelope. And O minus E, if O minus E has variance V, then if you divided O minus E by 10, you divide its variance by 100. So if you divide O minus E by V, you'll be dividing its variance by V squared. So B has variance 1 over V. And now we can see why a big variance for O minus E means a small variance of B. In other words, we know the log odds ratio accurately. So it's because the variance of the log odds ratio, the estimate of log odds ratio, is 1 over the variance of O minus E. And that's that corresponds to the variance of O minus C being the information content. So big information content means small variance, your estimate of log odds ratio. And if you were combining log odds ratios, then just simple summation of the O minus C and V is the most efficient way to do it. It does not assume, and this is really important because people get it wrong again and again, it does not assume that the odds ratio, the true odds ratio is the same in all trials. There is no such assumption. It's just what you get is a weighted average of log odds ratio in each trial. It's a weighted average, and that doesn't assume that the results are identical in all trials. This is often referred to misleadingly as the fixed effect method. The reason it's misleading is because it does not assume that the effect is the same in all trials. Remember, all we're going for is sort of semi-quantitative extrapolation. So, and this works for moderate effects, moderate treatment effects, but if you're talking about anywhere in the sort of range of a twofold relative risk, halving risk or doubling risk, then it's a very good approximation. Okay, so adding up the O minus C's from separate studies can be used comfortably, even by people who don't know exactly why it's optimal. Now, meta-analysis should use these weighted averages. I call them assumption-free weighted averages because I want to emphasize they do not assume that the effect is fixed. People talk about fixed effect models and random effects models, but the fixed effect model is this weighted average that I'm describing, and it does not assume fixed effects. So it's a term that was invented in order to denigrate this method, and it misunderstood the method, and it's in wide usage now, and it's unfortunate usage. It's better to describe these things as assumption-free weighted averages. And where there seems to be substantial heterogeneity between the results of different trials, random effects models give substantially greater weight to the deaths in the smaller trials, which is not appropriate. Think of Magnesium. And if there's only one large trial, then each death in a large, if there's, ISIS 4 was a big trial with 58,000, each death in the ISIS 4 trial would virtually ignored by the random effects models. It basically dominated by what happened in the small trials, which illustrates the loopiness. So in the case of magnesium and acute MI, and in the case of the high-dose vitamin A capsules in kids, standard random effect meta-analysis will find highly significant benefit, no matter what the big trial says. So it just doesn't matter what the big trial says, the random effect model is going to say this stuff works. So there's the random effects model, there's the magnesium data again. 8% dead versus 8% dead overall. Well, okay, no apparent effect. Slightly more deaths than those who got magnesium than those who didn't. All the trials were randomized 50-50. Relative risk 1.003 when you take all the trials and you give appropriate weight to the big trials. And there's the... Now, the last example I'm going to take is a very current one, which is the beautiful recovery trial, which has been testing a succession of treatments with COVID, showing that lots of things that were touted as working don't work, but coming up beautifully within its first 100 days, with the most important result thus far achieved in COVID treatment, in drug treatment of COVID, which is that dexamethasone, when you're giving people gasping for breath and on the way down and out, just dexamethasone, a cheap drug invented in the 1950s, £5 for a complete course of treatment, reduces mortality in patients who are actually getting into trouble. And so the top left panel here is the overall results from the recovery trial, and the top right, which is the interesting one, is what about people who are actually in intensive care on mechanical ventilation? They're horrible, really at high risk of death. Well, it's taking about 40% dead down about 28% dead. It's preventing about a third of the deaths. But I don't know if it's doing exactly that, but it's a beautiful result. Very, very strong. And then the bottom left is the ones who are oxygen only, but ones who didn't actually have invasive ventilation. And the bottom right is the ones who weren't on oxygen at all. It points non-significantly the other way round. Whether there is some adverse effect in them, I don't know. But the key thing is that steroids, corticosteroids, really, really protect patients who are gasping for breath. But it reduces their risk of death very nicely. Now, a meta-analysis of this came out a few months after the recovery trial published their results. And here's the meta-analysis. And you'll note that at the bottom, so at the top of the dexamethasone trials, and the square sizes are proportional to the amount of evidence in them, and the blue diamond underneath it is the weighted average of them, basically by adding up O minus E. And Then the next one's a hydrocortisone. They're small trials. You can see the middle one, COVID steroid, was 6 out of 15 versus 2 out of 14 deaths. So it seemed to say that the deaths was 3 times as common if you got the steroid. Yeah, but that's based on 6 versus 2. It's not serious evidence. And then the bottom one was pretty small numbers too. Methylprednisone, 13 versus 13 deaths. Okay, so that's fine. If you take the weighted average, then you get an overall relative risk of 0.66. So with very narrow confidence limits, 0.53 to 0.82. So a difference of more than 5 standard errors in mortality. I mean, it's a beautiful result and a very cheap drug. And it is the most important result for drug treatment of COVID. So the weighted average for all trial results reliably demonstrates definite benefit. Now, here's the graph they actually published, that the group actually published. It's got exactly what's being shown now, plus an extra white diamond at the bottom. And the white diamond is a random effect analysis of exactly the same data. So the blue diamond towards the bottom, the small blue diamond towards the bottom, which is the weighted average of all the trials, gives what I would consider the correct answer. The white diamond shows what you get with the random effects model. So instead of being 5 standard errors massively significant and transforming worldwide practice, you would conclude that, well, the difference is not significant and it's sort of marginally significant. Actually, the 95% confidence interval includes 1. And of course, it's because it's given enormous weight to the deaths in the small trials. So I'm going to go the other way around. So this is a current example. These mistakes are still being made. Most meta-analyses that are published involve random effects models. And I think that it's, for randomized trial results, I think it's always inappropriate. There may be some circumstances in other questions where it's useful. I don't know. I haven't yet seen them. I've been looking for them. So, summary on last slide. We want to assess moderate differences in mortality. We need all the main trial results to avoid undue emphasis on particular studies. Likewise, we've got to avoid unduly data-dependent emphasis on particular subgroups. I'd say we've got to avoid unduly data-dependent. Sometimes you're forced to say, well, it works in one subgroup and not in another. Look at the results for dexamethasone. Maybe that's an example. And for tamoxifen, it doesn't work if you don't have estrogen receptors on your cancer cells. So it could be, it's not saying there's never subgroups where things don't work, but it's the unexpected, it's the unpredicted subgroups that just are churned out by computers and believed when reported. Don't believe them. And so I think that the methodological thing, which is what I wanted to do in this talk, I've been wanting to talk about random effects models for some time because I am disturbed that we're doing damage with them and that they could kill people. I think it's a footnote. Just don't give events in smaller trials a much greater weight than those in larger trials. So avoid using random effects methods. And standing back even further from this, the key need is how do we get large-scale randomized evidence? It doesn't matter how good your methods of analysis are going to be. If you don't have large-scale randomized evidence, then you may well finish up with the wrong answer. And for that, I think it's the changes need to be made in how easy randomization is made. We've got to find ways of facilitating randomization. COVID has just demonstrated beautifully the importance of randomization. It's just been a sort of incredible 2 years for randomized evidence. It's so important that it needs to be facilitated. At the moment, all the pressures are to make things more and more and more difficult. This really needs to change, but that's another lecture. But it all fits together. We've got to get large-scale randomized evidence, and we've got to interpret it properly. Thank you very much, and I apologise for the delay in arrival.
It's so obvious, random versus fixed models. But why people still use it? Are there any circumstances, for example, in older epidemiology, where there might be some case for using random? Perhaps you can clarify.
I think that they're superficially attractive random effects models. I mean, they describe their assumption as being, well, look, there are going to be differences between the results in different trials. Yes, there will be. I mean, I would assume that different trials would, for some reason or other, really have different relative risks, even if the trials themselves are too small to demonstrate this. So whether or not we've got significant heterogeneity, I believe that there is heterogeneity between the relative risks in different trials and between the relative risks in different subgroups. But it's usually because the tests for heterogeneity are so crude that I believe there's heterogeneity no matter what any tests ever showed me. But people then, it then seems natural to say, well, if the true effect in different trials actually, if they differ randomly from some overall average, then shouldn't we actually put in a component of variance representing that difference? And that's why I wanted to start off with the case of the ISIS-2 trial, where you've got one trial that's assessed that question. If you've got only one trial, what are you going to say? I suppose the random effects model would say, okay, this trial came down heads, 5 standard errors in favour, so maybe there's another trial that's going to be done next time round that's going to come around with the exact opposite effect. And that would be a silly way of interpreting ISIS-2. So I wanted to try and discuss how would you go from a single trial to making sensible statements about patient treatment decades later. And as I say, we want semi-quantitative extrapolation. But I'm not regarding ISIS-2 as a random sample from any universe of trials that might have been done. So I don't need to know the variance of trials done that might have been done in a different way with aspirin. I mean, it might be tested in people over 80, and that might have given a different relative risk. Who knows? Or somebody could have done it in Chinese populations. That might have given a different relative risk. So in using the ISIS-2 result, we can extrapolate from it to the future patients, to types of patients who weren't in it, semi-quantitatively. And the further we extrapolate, obviously, the more uncertainty there'd be. I mean, to take an example with stroke, I mean, if you've got, there's 2 main types of stroke, hemorrhagic and ischemic, and if you've got treatments for ischemic stroke, which are, due to blockage of the blood, and you apply them to somebody who's had a hemorrhagic stroke, you might really well get opposite treatment effects. Like treatment might be favourable as a treatment for ischemic stroke and actively dangerous for treatment of hemorrhagic stroke. So you could get real differences between subgroups or between trials in different circumstances. But what the weighted average says, it says, given the studies that were done, what is the weighted average of their results? And then we can use that weighted average for this semi-quantitative extrapolation of the relative risk to patients much wider than a universe of patients in those trials. And I think that, and we don't need to say that the ISIS-2 trial came from some universe of possible trials, and that we can't say anything about whether aspirin does any good or not until we know the variants that would have happened, had different trials been done. And actually, I don't think it's a very interesting question or population to address. But you can see how a casual parameterization of the problem could do that. I think it was done by social scientists who weren't really thinking about how trial results should be used to extrapolate to patients who differ in ways that we don't know from those in the trial.
There was a question.
Again, could you take your mask off while speaking, please? I'm sorry.
You go.
You did.
So I have always been critical of most papers I read, and now I don't understand how would they read meta-analysis, because usually they.
You don't understand what? Sorry.
So I have always been critical of most meta-analysis and most papers I read.
Yeah.
I have been critical, but now after this section, it would be even harder for me to believe the result of meta-analysis, especially because they report just one result. They usually don't report average and weighted. So how?
They usually don't report average.
Average or weighted. They don't report two.
Well, no. The weighted average is what you get if you just to add up O minus E from each trial. Just take observed minus expected in each trial, add them up. That gives the deaths in the treated group.
But in the published results, they don't report it. They usually give the average.
The average of what? You're talking about publication of one trial or a meta-analysis?
Most, in general, most publications, most meta-analyses that have been published.
Yes, I like when I do meta-analyses, I prefer the observed minus expectors and their variances to be visible, because then you can see what it is that's being added. and you could see the effect of just taking out one or other study from that grand total.
So if it is not your meta-analysis, how would we, how to read it, or how to interpret it, or whether to believe it or not, if it's not?
Well, I think the first thing is, do you have large-scale randomized evidence with a massively conclusive grand total, with a massively convincing overall result? Because you need that, really. I mean, it's difficult to trust a 2 or even a 2.5 standard error difference if in a single trial or in a meta-analysis. Because, you know, if you've got a 2.5 standard error difference, then your 99% confidence interval will run from no effect up to twice the effect you seem to see. So you've got almost total uncertainty. You've got reasonable evidence that something's going on, but no idea really how big the effect is. So we really need differences of a few standard errors, you know, if we want to try and determine the treatment of millions of patients a year. I think there are some. I mean, the analysis of the cholesterol lowering trials, the cholesterol treatment trialist collaboration, the analysis of the antiplatelet trials, you know, the antiplatelet trialist collaboration, which then expanded into the antithrombotic trialist collaboration, these produced results that are overwhelmingly, massively significant. And so the overall results are trustworthy. They're trustworthy as to what the effects of those treatments were in those trials, and then you can extrapolate from that. But I think that we need much stronger evidence than is currently considered strong evidence to really be certain that we even know what happened at the time the trials were done, let alone really extrapolating decades into the future with very different patients. But I think if you think about how would you extrapolate if the ISIS-2 was the only trial of aspirin in the world, think about what you're saying, think about whether it makes medical sense. And I think it does, as long as you don't try and do exact, you know, you can't extrapolate the absolute gain, but you could perhaps extrapolate semi-quantitatively the relative risks. But if you think about what you're doing in extrapolating from ISIS, then that's what you're doing in extrapolating from a meta-analysis. Actually, a meta-analysis, which is, you know, reasonably well done, and a single trial, if they're both giving large-scale randomized evidence with definite effects and quite narrow standard errors, they're really very comparable in terms of their utility. But unfortunately, most trials aren't big enough to answer the question they address reliably, and most meta-analyses aren't big enough, don't involve large enough scale randomized evidence. That's the thing we really need. We need more randomized evidence. If we're trying to let it govern, you know, one question, you know, look at the breast cancer meta-analysis. I mean, they've affected the treatment of tens of millions of women, and so have the cholesterol treatment trialists and the antithrombotic trialists meta-analyses. And it can be done, but I think we need larger scale randomized evidence than we have, and then you'll probably find that a lot of studies finish up giving informative answers. And of course, for things like the vaccine trials, the COVID vaccine trials, the early results there in November 2020 were just brilliant. I mean, the relative risks were about 20. So it's easy to extrapolate and say, look, definitely these vaccines, at least in the short term, are providing at least short-term protection for, will prevent more than 90% of cases. I mean, it's really very nice. And then, we've now got to extrapolate from what was seen in those trials, which mostly were even before the alpha variant had emerged, into the alpha, beta, gamma, delta, omicron. So there's an extrapolation. Is it reasonable? Probably yes, because the vaccines actually, you do get antibodies, but would it be the same relative risk as in those trials? No, probably not. And does the relative risk in the first few months after vaccination carry on into the next several months? No, we now know that it doesn't, although it might do for severe disease. It might be that for severe disease you do get long-term very strong protection. But the meta-analysis stuff it's not a mathematical question, it's a sort of common sense question. And the use of randomized evidence doesn't assume that the randomized trials are like any sort of population that you could ever reconstruct. I mean, who knows what patients went into the original streptomycin trial? I don't know, they had TB. But the results were so striking that we can correctly conclude that streptomycin really does reduce your chance of dying in the near future from TB.
Richard, one thing we're talking about with MSc students is the fact that a randomized trial might be done. let's say the primary outcome is null, but one of the, like a tertiary outcome is maybe looks attractive, and maybe it happens to do so in another trial, and then somebody unhelpfully meta-analyzes these supposedly promising non-primary outcomes and produces a kind of preordained attractive result for something that wasn't the original intention of the trial.
Yeah, I mean, really, when you analyse data, you can analyse data lots of ways around. I think the whole business of exactly what's the primary outcome and what's the statistical significance level, it gets a bit oversold. You've got to do a statistical analysis plan. Well, I mean, nobody in the recovery trial had any idea how big the study was going to be, and they couldn't do. And nobody knew how the epidemic was going to go. I mean, eventually, we happened to be in the worst country in the world for COVID deaths in the early phase, with one of the best record systems in the world and also the best trial organisation in the world. So, it just worked beautifully in terms of getting clear answers. But nobody really knew. I mean, there was in the original recovery protocol, there wasn't a statistical analysis plan, except they were going to look at death, and then and also at the progression to the need for ventilation. But that was about it. I mean, it really wasn't there. I mean, nowadays, things, the dust has settled, and they're coming up with statistical analysis plans and so on. But at the beginning, to just get them randomised or work out what sense to make of it later, get big enough numbers randomised. And the other thing is, if stuff's so marginal that you've got to decide is it pre-specified or not, it's probably not very conclusive anyway, Rand. I mean, we really do need better evidence than that to decide how the world should proceed. I mean, these questions matter, and because trials now are so often done with commercial sponsors for regulatory approval, then they've got sort of opposite biases and all these rules as to exactly what you've got to do, what you haven't. I mean, the key point is we just need much bigger numbers. We need to get to political structures. Political structures allow that. Because the other thing that meta-analyses have done, because we've got lots and lots of different trials addressing tamoxifen, we can get overall evidence that's massively significant, which you never be able to do in a single trial. But I mean, basically, we need to work out how do we get randomisation happening like pre-Avalanche? How do we make things simpler?
So I know there's questions in the room, but I also know that time has moved on. So with regret, I'm going to say that we should probably close up. And I know there's questions online as well, and I hope. Yeah, but with apologies to everybody who's still online, we appreciate you sticking with us. And maybe we could ask if you have questions, you could always send them in simply by email. But I think.
Can I just answer that one back? Why do I say phasing trials are nonsense?
That's a good point to close on.
Well, it is. It's a sort of detail, but in the West African Ebola epidemic, they randomised a treatment called ZMapp, an antibody treatment called ZMapp, and they got sort of 8 versus 13 deaths. And by the time they published in the New England Journal with a Bayesian analysis, they concluded there was 95% certainty that ZMapp was saving lives. Well, you can't. It's a sort of nonsense conclusion, and you've had some of the same thing with I think the REMAP-CAP trials of various COVID treatments have perhaps overstated the definiteness of their conclusions by these rather obscure Bayesian things. And the trouble is that all sensible thought has to be Bayesian. You start off with the plausibility to you of some idea, and you've got your prior plausibility of an idea, then you get evidence, and if the evidence is strong, it might modify your prior judgment. It might modify it quite substantially, but you come to a trial with your prior judgment and with the data, and then you get a revised judgment, if you like. It's introduction, methods and results, discussion, and different people may differ. It depends. If the data is so strong that it actually swamps any prior judgment, then okay, the data is the only thing that's of interest, but often you do have to talk about prior plausibility. And even when I'm talking about subgroup analyses, how plausible is it that there could be a qualitative difference between the effects of aspirin in male and female? Not very, to me. I mean, it's not that it's impossible, but it's not very plausible. And so if I saw that, my Bayesian approach to that, I mean, just common sense approach, I call it, is, well, I don't believe there's going to be that big a difference. So I'm going to trust the overall results as a guide to what's true in male and in female. And that's without assuming that it's necessarily the same. And so there is that sense in which all thought has to be, prior judgment, and judgment. I call my opinion is judgment. I call somebody else's prejudice. It's the same word, but you've got to have that structure of thought. Otherwise, you just get nonsense. You can't just go by p-values and nothing else. It's got to be plausibility. But I think the key thing with trials is starting off with the right things about plausibility. And so much of what is called Bayesian analysis in trials actually involves inappropriate assumptions, I think. So I think Bayesian analysis of trials have given Bayesianism a bad name. And you've got to be serious about, in a sense, your prior distributions. If you're going to seriously get conclusions, where you've got prior distributions, evidence, and conclusions, if it does depend on your prior judgments, then you've got to be serious about what those prior judgments are. And I want evidence that really is robust against a sort of range of prejudices. Okay, thanks for that question anyway, because it is an important one, but it's a detail. But it's just Bayesianism gets given a bad name by people going in without being serious about what the priors are.
Okay, everybody, I think you'll join me in thanking Richard.